So here at the International Myeloma Society annual meeting, I had the chance to review the advances in induction and consolidation therapy in newly diagnosed myeloma, particularly how it relates to the duration of therapy. And what we have seen over the years that we had, first the establishment of triplet therapy with based on proteasome inhibitors, immunomodulatory agents, and how that performs better than combinations with the proteasome inhibitors and inoculators, as showing now in a couple of trials. And we also revealed the more recent advance on this field, which has really been the incorporation of monoclonal antibodies, now showing in at least 2 randomized trials and others, including our own master study, the high rate of deep responses and sustainable responses when you develop a quadruplet regimen with an IMid, a PI, and a monoclonal antibody. So that should be really the cornerstone going forward on how we shape therapy in newly diagnosed myeloma patients. We talk a little bit about consolidation. Most of those regimens have been developed in trials where patients get induction and consolidation therapy. But it's very clear that the baseline disease risk is quite heterogeneous on those trials, and patients have a different depth of response. So a lot of what we discuss is the next generation of trials. We really take the depth of response, particularly as assessed by MRD, and have that as a pivoting point to ask escalation questions for patients who have less than optimal response, but also ask de-escalation questions, particularly in how we can safely omit transplant on patients who have a deep early response to those now considered optimal regimens.